clarify so y'all understand what you're being asked. Which one needs clarity? They say I'm wrong. One, I bring cough medicine to use, and that's why I don't wake up my roommate. There's nothing wrong with that. There's a part of me that don't like this because you shouldn't be taking cough medicine just to satisfy a roommate. They need to cough up that fleas and stuff. So I'll come back to that. Two, I'll contact the college health center and pass all my medical records. There's nothing to clarify. You won't do that. There's nothing wrong. Three, I'll check to make sure that you still have a facility for me to exercise. What's wrong with that? Stay in good shape. Four, I'll carry you a hand hygiene product and stay away from sick rooms. I like one, and I'm gonna write it down. Now you do have to turn this in through email once you get through, so go ahead and this is your pre-test. Okay, so we got first, and then we're gonna go to the rationale in 1 second. So looking at the rationale, the answer is 1, and it's saying that exactly what I said. You're gonna see the picture of the rationale, so read through it carefully. The health plan will see this is on negative. Okay, so we got that one right. So we're going to the next one. Okay, so this says the nurse is assessing. So the nurse is looking at it. You're assessing someone. You're looking for anything that's going to come out different from what is expected. If you know that the sun's normal color is yellow and you assess it and it's red or any other color, through your visual calculations, you have spotted something that's not normal or normal. Okay, so the nurse is looking or observing the client's post-heme-laryngectomy. So they had a heme, which is half of their larynx is removed, and radical neck dissection for treatment of cancer. Which finding should be expected to the surgical procedure? A permanent loss of voice. Now that, I think that is a lot of voice loss. Hold on. Shoulder drop only on one side. That is like a stroke. A stroke. That's not saying anything. Numbness of the mouth, lips, and face. And it really causes clear secretions. So your larynx is your windpipe. I think it's a permanent loss of voice. Which finding should the nurse expect due to the surgical procedure? It was clear. Causes clear secretions. I'm gonna say 1. Shoulder drop, and we're gonna look at the rationale, and it's right here. I knew that. Okay. During it's 2, so the answer to this one is 2, and we're gonna read why. During a radical neck dissection, the 11th cranial nerve, the spinal accessory muscle is severe, resulting in shoulder drop on the right side of the dissection. So right now you will go and look up radical neck dissection. So we're gonna go to that.
To the neck, resulting in the appearance of an enlarging neck mass. Normally, lymph nodes in the neck filter substances that travel through the lymphatic fluid and help the body fight infection and disease. They are connected to one another by lymph vessels that are abundantly bound, especially around the blood vessels under the sternocleidomastoid muscle. However, its variability to filter disease is why cancer may present as an enlarging neck mass as it becomes infiltrated by cancerous cells. Depending on the exact situation, the cancer may be primarily treated with radiation with or without chemotherapy. Surgical excision may also be performed either as the primary course of treatment or as salvage after radiation and chemotherapy if residual cancer is felt to be present. When surgery is pursued, the goal is removal of not only the cancerous enlarged lymph node, but all surrounding lymph nodes as well to eliminate any possible surrounding microscopic spread that would otherwise be missed. Known as a modified radical neck dissection, important anatomic structures specifically including the sternocleidomastoid muscle, jugular vein, and accessory nerve are all preserved to minimize post-operative morbidities. However, should these structures be involved with cancer, they will be sacrificed in order to minimize risk of future cancer recurrence. Removing the internal jugular vein may result in increased intracranial pressure. Removing the sternocleidomastoid muscle results in a noticeable cosmetic deformity, altering the normal contour of the neck. And finally, cutting the accessory nerve results in the inability to shrug the shoulder. As such, all attempts are made to preserve these structures as long as it is oncologically sound.
Okay, so you want to read each rationale. So we understand that in this massive surgery, the muscles is severe, and even the lymph nodes are removed, and that nerve. Okay, just watch the video again. But it's like they're gonna they put a big hole inside of your neck, and it's covered with skin, so it's not too protective, and that muscle that's there is severe, so you won't be able to have your shoulder the right way. Okay, so that makes sense. It's surgery for of course, to say cancer. So now you know what heme-laryngectomy is. Heme is half of it, but it's still in that surgery. That muscle is still going to be affected. Okay, the next question. So it's 2. Shoulder drop only on one side. That's where it's at. Okay. Now we're on 1491. I'm gonna go ahead and it's a little bit out of order, but that's okay. That's for me. We just you got your number beside this second one. Okay. Oops, excuse me. Hold on. All right. The nurse is evaluating discharge teaching. So she's reviewing the discharge teaching that has been completed for the client following total laryngectomy. It's your larynx. That's your voice box. Which client statement should the nurse correct? I will be sure to carry an extra supply patient tissue with me. Nurse correct. I think this one is a problem because the laryngectomy, we don't want any kind of. Let's see. I'll probably not be able to go swimming at all anymore. I don't know, I would plan for a closure of my costume in about a month. So remove your trachea, closure. This has been removed. I would check the osmosis batteries are working. So there's nothing wrong with that. I mean, it won't be nothing wrong with your extra supply tissue since I'm looking at the others. I will probably not be able to go swimming at all anymore. I plan for closure. I think it's 3, so we're going to go 2 and 91. It's 3, so the answer is 3. And here what it says. The nurse should correct the statement by the client. The tracheostomy is permanent after total laryngectomy because the larynx and part of the trachea are removed. So tracheostomy, you have the trachea is talking about your trachea, and ostomy is the creation of a hole. This is some medical terminology for you, breaking it down. So you can go and look up what tracheostomy is, and let's go ahead and do that. Okay, wait before. So let's read the other rationale. Swimming puts the client at risk of aspirating water into the avoided. So you got your removal of your trachea, your breathing, a part of it. You don't want to go swimming, you don't want to do that. Trying to carry extra tissue because using negligent increases in the problem of managing oral secretion basically. After the surgery, you're going to have a lot of saliva. So, 4, the client's officer is a concern in the home. So, I'll check out when they're not working. So during surgery, you know, the nose will not be working properly. Of course, just had surgery, so have it so detected. So let's go look at the surgery. Okay, here's that.
Surgical deconstruction. A U-shaped incision is made and the visor of skin lifted. The sternocleidomastoids are retracted laterally. Once the strap muscles are raised, thyropharyngeus and cryopharyngeus are revealed and shaved off their respective cartilages. The suprahyoids and middle constrictor are dissected off the hyoid, revealing the pharyngeal mucosa. The hyoid bone is depressed, and the pharynx entered from above the epiglottis. The trachea is divided below the second tracheal ring. The larynx is separated from all its attachments and removed, leaving an open pharynx. The endotracheal tube is transferred into the tracheal stump for ongoing respiration.
Okay, so you can always Google a question. So this surgery is going to remove your voice box, which is your larynx, and part of the upper trachea, separating the upper and lower respiratory tracts. So these are performed for cancer, to treat any kind of severe trauma, but so that you can continue breathing. You have to understand that in this surgery that there is a new opening created. Ostomy, there's a new opening. So when they cut off part of your voice box that's connected to the trachea, which could be damaged from trauma, and it needs to be removed because it can get infected, you know. So removal of that damaged piece is still creating an opening for your trachea, which is new, you know, because part is not its normal form anymore. So this is permanent because they're removing part of your voice box that's connected to your larynx. And they don't need to risk going swimming because they just had surgery, and it's very easy to get that water stuck and then new. You just don't want to risk that. You gotta make smart choices. Alright, so the nurse is assessing the client post-tumor laryngectomy. So this is after they just had half of their larynx removed. Okay, and radical neck dissection for treatment of cancer. This is the surgical procedure. Are we going backwards though? Okay, yeah, sorry. I didn't do it. 1 second. Okay, our next is just turn the phone so that it makes sense to your brain. The nurse is preparing to perform tracheostomy care for the client with laryngectomy. So tracheostomy is cleaning up that it has secretions in there. You know, they're sick. When after you have surgery, your white blood cells are going to go a little bit. The viral infection and your secretions are going to increase to try to make sure there's nothing to contaminate in your trachea, which is sterile. So we're going to prioritize steps nurses take to correctly perform this client's tracheostomy care after assessing the client and explaining the procedure. So the procedure is going to clean your equipment that's helping you breathe. And most important thing, remember, you have to give them option to do this procedure. Okay. So first, as our options apply, there's 6 options. Okay, but there's 7. So we're going to go ahead and make 7 little slots. 1, 2, 3, 4, 5, 6, 7. And you're going to put the one that's first, and most important first. Being clean, trying to be clean. Apply clean gloves. I'm gonna put that one up here. Yeah, I like it. We do wash hand first. 2, wash hand with apply sterile gloves. I like 2, so I'm gonna make 2 my first one. Wash hand with sterile field. That one's tricky. After wash hand with apply sterile, wash hand with sterile field. So 2 and 3 gonna go here. So clean the inner cannula. Clean the cannula. So the first thing I'm going to do is clean the incision site and tracheostomy tube. Okay, that's gonna be last. I'm gonna remove the inner cannula. So my second one's gonna be 6. I'm gonna work this out while I'm gonna show you why. I'm just gonna watch the process.
Begin by opening the catheter and connect it to your portable suction. Remove the packaging and turn on the portable suction. To ensure the catheter is clean, put the end of the catheter into a clean solution and occlude the catheter. This allows suction to occur. Without placing the catheter down, remove the cannula and set it in a clean solution. Insert the catheter about 4 to 6 inches. Occlude the suction and rotate the catheter as we're removing it. Rinse the catheter. Replace the cannula.
Okay, so watching the video, they didn't really do a good job with saying, you know, wash hands and all that stuff. So I had 1, 2, 3, 4 out of place. But so the first thing you're going to do is wash your hands and establish a sterile field. You need to have to a cleaning solution that's going to clean the inner cannula, which is sterile, which is mostly important. It needs to be in a sterile area. So you need to wash your hands and get that field going. The next thing you're going to do is wash hands with gloves. You're going to remove 2, 3, and then 3 and 1. Excuse me. Wash hands, establish that sterile field so that your ground where you're going to have your tray and stuff is clean. The next thing you're going to do is apply clean gloves. So now you need those gloves to remove the outside of that inner cannula is not sterile, so you can use regular gloves there. It's the inside of it that's what we're trying not to touch. So once you got your table area sterile, you're going to wash your hands and get sterile gloves, and you're going to remove that inner cannula in hopes that you do not touch the end of it, you know what I'm saying, after touching the top of it, okay? And you're going to drop that in a cleaning solution, okay? Wash your hands in a sterile field, apply clean gloves, but you got to do some order if you're doing it for real. Then you're going to remove the inner cannula, so that's 6, and place in a cleaning solution. Next is wash hands with sterile gloves. So now we're about to be inserted. So we get those sterile gloves. And we're going to clean the inner cannula with our sterile gloves. Okay. So 6. Then it's 2. Wash hands with sterile gloves. Then 4. Clean the inner cannula. Then 5. Reinsert it. And then 7. Clean the incision site. So we know how to rationale for you to understand. We saw the video to get you to understand it. It's a secret 4. Okay. 1489. That's a bit tough. Okay. Nursing for the referral to a dietitian to plan care for the client on total laryngectomy. So there has to be a diet with it. You don't want nothing hot, too hot, nothing too thin. It can make it easy to aspirate. Okay. Which is the nurse primary nurse? I'm going to show you how to do it. The client like the presence of constipation eating. No, the client needs loss of sense of maybe. The client's loss of sense of smell, which affects eating. The client must not judge with aspiration. The dietitian is not going to do that. If anything, the client like the presence of smell is going to have to swallow differently. Primary Russian brain is dietitian. Maybe it is one. Let me look at my one. Okay, so the loss of smell of, and the answer is 3. So you gotta remember what we learned about a certain type of situation and carry it on to remember it. Because we just talked about nerve about how that facial nerve and muscle is severe, so it'll be hard to not only lift that shoulder, but facial movements and stuff like that and smell. So and a lot of times if you don't smell it, you don't eat it, and it can cause nutrition problems. So you have a dietitian to find out which food are best to eat for the instruction. You'll read the rationale. Their aspiration is not a concern. There is no continuing immunity between lungs and the esophagus. So you still have the epiglottis. It's more that nerve and severe that prevents you from smelling like food. The depression is not for the dietitian. We learn to swallow. That's we learn how to swallow is with a total laryngectomy and not a partial. Okay, that stuff matters. Let's see what number we are. And the next one on the 3rd. So this is 3rd day after surgery, post-operative, following a total laryngectomy. Remember what we read about that nerve and that shoulder, because it's just skin holding it together. You know, the client's spouse asks when the client will be able to eat, which responds by nurse is correct. He will be fed their feeding tube, eventually will be able to eat normally. So the laryngectomy, the esophagus on top of that. And it's just, okay, let's see. Before eating, he will need to learn different ways of swallowing during aspiration. There's no aspiration here. Okay, this is total or partial? Okay, this is total. So understand that we take information from the previous questions that we remember. In total, there's a risk of aspiration here. Okay, because of his surgery, it will be several more days for his GI function again. There's nothing wrong with the GI function here. He would like to receive his food through a gastrostomy tube placed in his stomach. Let's see the rationale here. But my answer would be 2. Before eating, he will need to learn different ways of swallowing during aspiration. So let's check that out. Okay, so the answer is 1. A feeding tube is generally placed during the surgical procedure and first used for stomach decompression and then for feeding until healing is near completion. Once healing occurs, the client can eat normally. So in a I hope this is opening your mind up to the care of tracheostomy. We know that it's the muscle and nerve that's severe. Understanding that there's a shoulder drop and there's a impairment with the nerves, the smell, and swallowing can be a problem if it's total, because it's the whole thing versus partial. It's a little small scat. We learned that during the procedure, there's a feeding tube. Feeding tube that's placed during the decompression. So they're going to get fed through a tube. Now I don't know whether it's a peg tube, so we're going to Google that. Okay, so a peg tube is what's used to, and I'll show you how to operate that as well, how to stop and fill it up and all that stuff. But they need that because this is a surgery that can affect their breathing. So it needs time to heal. We don't want it to get infected. We don't want it to get pneumonia, which they are at high risk for after a surgery. So you do a peg tube until it's healed, almost near completion, if not completely healing. And then they can go back to normal eating. So when we go back to the question for the further reviewing, we understand he will be fed a feeding tube, but eventually he will be, yes, he will. He just had the surgery on the 3rd day after it is not healed in 3 days. So that, now too, before eating, he will learn that new way of swallowing. He's going to have a peg tube that doesn't require any swallowing on his behalf. Because of his surgery, it will be several more days before his GI function begins again. That has nothing. Regardless, you need food to heal and to survive. So worry about GI function at this time. Like if you had a section of the bowel, you'll still have some kind of form of food. You know, it might not be on your regular diet, but parade or something that's going to help get your nutrition up. He always receives his food through a gastrostomy tube placed in his stomach. Gastrostomy tube, this is a stomach tube directly in the stomach. There's no need for that. It's just a sort of neck. So a peg tube, 1 second. Okay, so I want to catch it. Now, he will, on number 4, he will likely always receive his food. Now, likely always, that always part is saying that it's going to be permanent. And if this is not, he's going to be able to eat normally eventually. So 4 is not a good one. I always receive his food through a peg tube. It's just temporary. So stuff like that is what would make you get a question wrong. So our next one, 47. The client had a total laryngectomy with tracheostomy placement. The nurse obtained 2 sets of post-operative vital signs that are within normal limits, which is the nurse's priority now. So, client had a total laryngectomy. I understand with this procedure, they might have some secretions, but their vital signs are normal. So now the prayer will check the stone for amount of mucus secretions. Okay, let's hold that. Reposition the client in a flat supine position. Flat, we need to elevate a little bit. 3, measure the amount of blood on the wound rest. Now, I like that. 4, change vital signs frequently to every 2 hours. I like 3 measuring the blood. Or check the stone for the amount of mucus secretions. Okay, first off, sorry. There's going to be a little blood on the dressing because they just had surgery. So the most important is the mucus secretions because it can block the airway. So we're going to go 1. It is 1. So that's why the nurse priority action should be to check the amount of mucus secretions at the stone because secretions are potential cause of airway obstruction. The next study should be taken into consideration. These patients just had surgery and this is with their direct breathing organ, tubes, so to get the air to it. So we want to check those vitals frequently. Although monitoring the amount of bleeding after the wound is important, it's not the priority. So when we're talking about priority, airway is first. So make sure the airway is clear, that the oxygen is getting in there, able to breathe. So those secretions are going to be in front if they're there and prevent them from being able to get the amount of air they need to survive. Okay, so then the second one, they should be in upper position, not flat, to prevent aspiration. Because if they just had surgery and they're bleeding at the site, that blood can go back and into the lungs and it can cause them to get sick. That's why we need a professional to do this. Our next one is 1486. We're going to read nurse scan for chronic post-operative mechanical ventilation, positive pressure. So they're going to be blowing in there. The client has been resistant to ventilation, assisted breath, so they're resistant breath, and the client's breathing has steadily decreasing. 1 second.
intubation is simply something we do all the time in ours. The problem with COVID-19, however, is on that tube, we would have to sedate you. Well, that requires medications. Medications that can affect your body in many ways. Long term, we're really worried about the side effects. Memory issues, weakness, profound issues with sleeping and wakening. And we know from scientific studies that vomiting on the ventilator, the chances of a good outcome are much lower.
Those moments just before we add the ventilator, watching our patients struggle to breathe, it's hard to watch as a clinician to see time and time again. This could be your last time that you get to speak to somebody.
Your family's not able to be there with you, and I think that that's the hardest part is, as a patient, you're basically...
appears to be more inflated even when the lung is going through the expiration or deflating phase. This is because there's PEEP being applied by the mask or ventilator at the end of each breath to ensure that the oxygen and CO2 exchange part of the lung or the alveoli are not so prone to collapse. PEEP commonly applies to a bag valve mask, CPAP, BiPAP, high flow, OptiFlow, and or the ventilator. Pressure that is applied or increased during an inspiration is called pressure support. Extrinsic PEEP can be used to increase oxygenation. By Henry's law, the more of a gas that's present in the air above a liquid, the more of that gas will dissolve into the liquid, aka this is how we'll get more oxygen into the body if you're suffering from acute hypoxic respiratory failure. This in turn increases the solubility of oxygen and its ability to cross the alveocapillary membrane and increase the oxygen content in the blood. Extrinsic PEEP is used in acute respiratory distress syndrome, which can be caused by sepsis, pneumonia, severe flu, a severe chest injury, accidentally inhaling toxic chemicals.
Okay, so understanding that when you're giving PEEP, a higher amount of oxygen is shoved into your lungs at the end of your breath to make more oxygen get into the blood. Well, your heart doesn't have to work as much to get this oxygen anymore, so the heart rate is going to slow down. Also, it's steadily decreasing, so we need to give a hypnotic something to relax things. It's gonna further relax that heart, but they have to put you on a sedative because just imagine a machine breathing for you. You're not going to be comfortable, so that can make some changes in your vitals as well. So you need to be able to calm down, and then with you upset and your oxygen is getting inside to where your heart rate doesn't have to work as much. It's a bad mix up there. So we need something to keep you calm so that that difference between stressing out and relaxing doesn't come to a rude awakening. So calm your patient down. Here, the nurse is preparing to check the cuff pressure on the ET to acquire serum mechanical ventilation. Let's next decide whether to check the cuff pressure. As you see, I have my mark here. And reading rationale, the correct location is at the inflation assembly, which connects directly with the tube cuff. No other location allows cuff pressure to be assessed. So that'll...
Cuff inflation should be done slowly to avoid overinflation and can be monitored by measuring cuff pressure. Simply palpating the pilot balloon is not an appropriate way to assess cuff inflation and may cause harm. Instead, cuff pressure should be measured using a cuff manometer and should be performed regularly and whenever air is added to or taken out of the cuff. A cuff manometer is designed to measure cuff pressure and can be used to inflate the cuff or remove air from the cuff of the tracheostomy tube. The gauge shows the pressure in centimeters of water. There is also an inflator bulb and air vent button that can be used to adjust the pressure by adding or releasing air. The inflator bulb can be used to add air to the cuff if the pressure is too low. The red air vent button located on the back of the manometer can be depressed to release air if the pressure is too high. To measure the cuff pressure, attach the manometer to the pilot balloon of the tracheostomy tube and note the needle on the manometer. That will reflect the measured pressure. Recommended cuff pressure is highlighted in green on the face of the gauge.
So we understand that it's important that it's not too tight because it can prevent air. Okay, so overinflation of the cuff meaning there's too much pressure. It can decrease the mucosal perfusion, meaning it's going to press on it hard to where it'll make those cells die, especially after a surgery. So if it's too much, if it's inadequate, it can lead to microaspiration, meaning things little small liquids like your secretions can dribble back and fall down to the lungs. So the cuff pressure has to be monitored to make sure it's the right level so people don't die. Okay, so when we come back, we understand why this is the area where the cuff pressure is checked. It gets connected to that ball, that circle. Our next question, 1484, decline hotspot. Spill lines at lower respiratory tract infection. So the lower tract is your lungs, like your throat and your lungs, versus upper is your nose or your throat. Throat is upper, and then your lower is your lungs. Okay. Or it could be bronchitis, or person with a history of mild liver disease and asthma. Which prescription might healthcare provider should we question? So albuterol, I have no problem with that, given that that's a good, we got asthma. Methylprednisone, this is a corticosteroid, and it has a meth in there, so it's going to decrease the effectiveness of your breathing. And you have, aspirin, Cefazolin, pain and fever, and then oxygen. I'm going with 2, so let's check that. 4, it's the aspirin use of aspirin is avoiding climate asthma because there's no trigger. Oh wow, I used to know that. Hold on. So given that aspirin, it'll cause asthma attacks, and I'm guessing in a sense, aspirin's a blood thinner, and it makes your blood run a little faster. So if you have a trigger for your asthma attack, that your blood is speed racing, so it'll trigger it faster. So I can see that. You have to make these things make sense to the brain, and once you do a lot more of these questions, it's gonna tie on in. So that it's asked. So what does it say about the 2? Yeah, that's okay. I was looking at the methyl part with the breathing because something like coffee or chocolate can make your breathing slow. So that's what I was digging into. So we learned that. 1483. The nurse assessing the lung sounds of the client with pneumonia who's having pain during inspiration and expiration. It hurts to breathe in and out. Okay, which information about lung sounds should nurse document when hearing loud grating sounds over the fields? Lung fields. Grating. Bronchial over the lung fields. Loud grating. Okay, that's like a pleural friction. That'll be, let's see, 8. Course, what? It's 83. Okay, it's 4. Good. Okay, I was reading the other one. So, pleural friction tends to be loud grating and easily heard in the lung field upon occlusion, suscitation. The pleural friction is also associated with painful breathing. So, you have a cavity. I'm going to go to a video here.
Let's listen to some audio of what a pleural friction rod may sound like.
Now, how do you know that you're hearing a pleural friction rub? Well, you want to pay attention to the timing. With pleural friction rubs, they can occur on inspiration and expiration, and they're going to have a low pitch to them. In addition, they can be discontinuous or continuous. It really depends on the severity of the rub and what's going on with your patient. And it's located in the pleural layer, which are the layers that surround your lungs, which is made up of the viscera pleura and the parietal pleura. In addition, it's going to have a defining characteristic that you're going to be able to know on auscultation. You're going to hear this harsh grating sound. In addition, your patient's probably going to have pain. This harsh on auscultation. On auscultation.
Oh, goodness.
And it's located in the pleural layer, which are the layers that surround your lungs, which is made up of the viscera pleura and the parietal pleura. In addition, it's going
So during this, those two, it's like a trauma or something like that. Both layers of your lungs are inflamed and they're touching each other. So it, you breathe and stuff, so they can hurt. And this is why it's painful when you breathe in and out. Yeah. So some causes pneumonia, pulmonary embolism, heart disease. So when those layers become inflamed. So clients admitted with possible PE, pulmonary embolism. In consulting with this HCP healthcare provider, the nurse learns that the VQ scan shows the breathing quotient mismatch, which intervention is appropriate. So relation, breathe in. There's a mismatch, meaning that the amount that you breathe in is not equal to the amount that's coming out. So I'm going. So it looks like to me further diagnostic testing with the breathing. So they're saying that the amount of air that you breathe in is not it's not matching up with the amount of air that's needed to be in your body. Okay, so let's go look up more on this. Hold on. So ventilation perfusion, that cues perfusion. Ventricular occurs when either ventilation or airflow or perfusion, blood flow in lung is impaired when lungs problem. So when you breathe in, you're not providing enough oxygen to your lungs to breathe, even though you're breathing. So this can let you know that there's a blockage of some sort, and it needs further diagnostic testing. A good understanding here, this is normal, air going smooth. If there's a shunt where perfusion, you're getting. Hold on. Okay, so with this first one, with the X on the vessel, you're getting, there's oxygen, but it's not able to get into there's something blocking, there might be some secretions, there might be embolus, something that's blocking the blood flow to the lungs, so it can't move or function or get oxygen in. On the other flip side, blood is flowing, but there's no oxygen getting in, so the ventilation is off, but the perfusion there's blood getting there, but eventually it won't because they don't have oxygen, but right now, blood is getting there, so there's not perfusion, there's not a blood flow problem to the lungs, versus if the ventilation where there's enough air but there's not enough blood flow, that's letting you know that there's a blockage, like an embolus or something, or damage to the lungs. So further diagnostic testing needs to be done. So you go down to 4, a VQ mismatch is not a normal finding, so it's not normal, it's supposed to be equal. Mismatch is highly suspicious but not diagnostic of multiple lung disease, including PE. It does not have, just because you have a VQ mismatch, it does not always mean there's an embolus. There could be something else. You could have infection. Okay, a chest X-ray, sputum culture grams are used to stop is not indicated. Okay, it's kind of so they're saying that they had an airborne disease because their mismatch is off. It doesn't necessarily always mean that, because you can have TB and you can still be perfusion and all that stuff. You have COVID and still, so that's not that. 181, helping the client. No. Oh, sorry, the nurse is helping the client newly diagnosed with a sleep apnea, obstructive kind. No, that's bad. And need to apply CPAP at bedtime when acting nurse, but the purpose of CPAP, which actually needed. The CPAP machine will breathe for you during your sleep. Use the CPAP will reduce inhaled pressure. Machine does high levels of oxygen due to the collapse of small air sacs. I like the way 3 sounds. 4 does sound pretty luring. Use the CPAP prevents collapse of small air sacs. With COPD, with sleep apnea, your tongue is preventing air from getting into your throat. So we need something to keep that open when it wants to close. So it's prevent the collapse of small air sacs. I like 3. So the rationale, 181. Okay, it's 4. Now, why do you say there's not 1? A ventilator and not a CPAP we used to breathe for clients unresponsive. 2003 for you doing sleep. Okay, so the ventilator is going to breathe for you, of course. So 4, CPAP devices are intended for clients who can breathe on their own but need assistance in maintaining alveolar oxygenation. The CPAP keeps the alveoli open, allowing for maximum perfusion to occur. So we're going to look at that. Normal airway. Okay. That tongue is blocking it. Okay, that's a treatment.
Your breathing pauses for brief periods while you're asleep. Normally, when you breathe in, air flows in through your mouth and nose and down your throat, also called the pharynx. Air then flows down your windpipe or trachea, spreading through a tree-like structure of smaller tubes into your lungs. Each time you breathe in, negative suction pressure pulls the soft tissues in your mouth and pharynx inward. The muscles in your pharynx respond by pulling the soft tissues outward again, which keeps your airway open. When you sleep, it's normal for the muscles in your mouth, tongue, and pharynx to relax slightly, but not enough to block your airway. If you have obstructive sleep apnea, the muscles of your mouth and pharynx may relax too much. Your tongue drops onto the soft tissue in the roof of your mouth, pressing it against the back of your throat. This completely blocks the flow of air into your lungs. The lack of oxygen in your lungs wakes you up. You may gasp for air to re-establish airflow before falling asleep again. The cycle of apnea and waking up may happen many times at night, preventing restful sleep. Factors that may contribute to obstructive sleep apnea.
It's important to know that those air sacs, when dealing with a CPAP, or air being given to you forcefully, it's going to always keep them open a little bit, so that it does not matter. You're going to have some oxygen there at all times. So it's just a little bit, we need to open it at all costs. So we go back to the question: the use of the CPAP prevents collapse of small air sacs. Yes, because when the collapsing is when the sacs are not able to feel air because they're collapsed. Okay, if they're open, always open, there's a portal for the oxygen to be transferred into the bloodstream always. So it's going to keep it open. The next one, I don't even need the rationale for that one. It's just, you always want to assess what you have. If someone's heart breathing is off and you got the probe to test it, and it's, oh, there's this little gap there, look at it again and make sure that it's right. You don't want to stress your nurse out if you could have rechecked it, and, you know, so the answer for it, right? The plus breath tracing, yeah, when you're checking someone's pulse ox, nail polish or not being on right can make it look like this line here. So assess it and get a different check on it. A call for Q rest routine, machine call maintenance. Do not remove anything. You don't do anything without an order, okay? Remove the machine and call maintenance and give oxygen through a nasal cannula or mask. You just have to check your information that you got. But you're not going to remove anything without an order, okay? Next. Okay, so this person here, they had a right-sided lung removal. At the end of the shift, they need 10 liters of oxygen to keep their oxygen rate 88. I understand a whole part of the lung has been removed, so the oxygen intake is going to be quite low. I'll be a bit low as compared to normal. Which I should be taking, but they have COPD. So a rule with COPD is that they don't supposed to have more than 3 liters of oxygen because that's going to make them bare chest and more unable to breathe. So I like one, call respiratory nebulizer for what? That's not, you know, check the respiratory status. I like to check the respiratory status and notify. I like 3 too. Work to wean off down. Okay. I really like 3 because I do want to wean them off, but checking his status. So let's see the rationale. It's 3. 79. You want to the uncommon notion to check the respirations and report the abnormal findings to the healthcare provider. COPD on high flow oxygen lose their respiratory drive with their common have developed respiratory conversation. So oxygen by maximum should be set at 4 liters or greater. Okay. So if they're wearing a mask, it's I understand different masks deliver certain levels of oxygen. So with a COPD patient, if they have a mask, it needs to be to where they can get it in. You know, versus a cannula, it's different. Next, the home health nurse is inclined with chronic bronchitis and worsen. It's not following previous instructions. You gotta follow the instructions. Instructions should be enforced. So they got bronchitis, which is inflammation of their bronchial tubes that connect to their alveolar sacs, or the tubes that draw the oxygen, carry it to the sacs. It's inflamed. So and it fills up with mucus, so it makes it hard to breathe even more. Which should the nurse reinforce? Increase the amount of bed rest. I like that water. So why would you decrease oxygen? You need carbs because you're going to be breathing. You know, you need that for energy. You want to increase your bed rest. But I like the fluid because it's going to thin out your secretions and make it easier for you to breathe. So what's the answer? The rationale for that is 2. You want to increase that fluid intake. 1 second. Okay, the client with interstitial pulmonary disease has trouble breathing and fatigue. This means trouble breathing, which recommendation by the nurse will be most helpful to define. So they got a pulmonary disease like COPD or emphysema. Use energy conserving measures. I like that. Use oxygen while at home. We want the most helpful. Okay, of course you're going to know use that. Remain in the upright position. Use controlled coughing for airway clearance. I like to use the energy conserving measures. Let's see what that's at 7. Yes, it's 1. Energy conservation includes use of rest periods or breathing. Technique is the only option for focus on both. Yes. There's nothing telling me that there's an ineffective airway. Although sitting upright would help expand lung. Yeah, so you're not gonna do too much exercise and you know you have a pulmonary problem. You know. Okay, well, you might need to hunch over a chair. A table to get some breathing. You know, you do that triad positioning. Okay. Alright, like, we just talking about it. The nurse enters the room, the client with COPD finds the client seated, and they're usually like this. How should the nurse document the client position? Orthopedic position? Yes. This is 76. Abdominal breathing position, first lip breathing. This is abdominal breathing position. I like the orthopedic. 76 is 1. Let's see. Yes, the chronic airflow issues is COPD is an orthopedic position, easy breathing. This is a tripod position, so that's what I was talking about, like a triangle. It's hard for them to breathe. Next one, the nurse is teaching the client COPD. About the purpose of first-lip breathing, which explanation is most important, to reduce upper airway inflammation, strengthen respiratory muscles, and improve inhaled drug effectiveness, reduce anxiety and heart rate. Now, I was between 2 and 4, but I like 4 because the first lip is going to help you calm down. So I'm going to say 4. It's 2. Okay. $14.74. The nurse is assessing the client with chronic bronchitis. Which findings should the nurse expect? Information of the bronchioles. Minimum sputum with cough. There's going to be a lot of that. Copious pink frothy sputum. Burrow chest appearance. I like 3. If they having the sputum, there'll be a pulmonary maybe a pulmonary embolus. It's gonna make that blood seep out. Okay, but barrel chest because it's hard for COPD patients to breathe. So let's do the rationale. Report is 3. Okay, good job. Next, the nurse and client are updating the client's asthma action plan, which information should be updated on the action plan. Drug adjustments for peak flow less than 50 of normal. Hold on. I really like 1. let's look at a peak flow of less than 50 of normal indicates that the asthma action plan should be updated. Yeah, worse than just what I made. Okay. Chest physical therapy, excuse me. It's not a part of asthma therapy. Plan should provide the best way to access them. Right, so a drug adjustment peak flows less than your peak flow. So with your peak flow, this is give you your healthcare provider information about how open the airways are in your lungs. And green zone, which is good, are between 80 and 100%. So given the question, if it's at 50%, then something needs to change, and you should do this every day so that you can have a better estimate on your breathing. So the answer is 1. Now on 72. The nurse says teaching the client newly diagnosed with asthma, which are instructions should the nurse include to reduce allergic triggers. Set like auto apply, wash bedclothes and cold water. I like 1, use dust cover on mattress and pillow. I like 2, keep house fresh with a scented deodorizer. I don't like the scented. I think there's a trickster here. So 4, vacuum carpets daily in bedroom. I like that. 5, clean the albuterol daily under hot running water. It should not be hot, more like a warm. So I like 1, 2, and 4. I like to keep the house fresh with a scented deodorizer, but I don't think I don't like that scented one. So let's check the Rationale. It's 2 and 4. Good job. So use dust covers and vacuum carpet daily. Oh, I said wash bedroom cloths in cold water, and they said it's not it. Bedclothes should be washed in hot water. Okay. Or cooler water with detergent and bleach too. Okay, so we want to wash with hot water and bleach. Okay. So that is 2 and 4. Okay. The client newly diagnosed with asthma is preparing for discharge. Which point should the nurse emphasize during the client's teaching? Contact the HPC if nighttime wheezing is a concern. Which point should the nurse emphasize during the teaching? Okay. Avoid source that might trigger an attack. I like to use peak flow meter only since it's start worsening. I don't like that. Use the enhanced steroid. It should be albuterol. 2. I like 2. 71. It's gonna be 2. Emphasize to avoid your triggers. Let's see why it's not 1. Since it's worsening. Anyway. There are 2 of the many symptoms such as worsening peak flow meter readings and nighttime wheezing are 2 of the many health changes that should soon decline to contact the healthcare provider. Okay, so you experiencing that is what's going to cause you to come in, okay? But we need you to avoid your triggers, okay? 70, the nurse is teaching the client about using the illustrated attachment to the meter dose. The nurse explained that this attachment is useful for allows a greater amount of making. I like 1, yes. Permits visualization. You don't need to see that anyway. Maintains sterility of mouthpiece. It doesn't do that. Used for activating medication something inhaling. It's going to be 170. It's going to be, and it is 1. It just makes it that extender. Makes you get a lot more of your dose. And now we're in the last one, which is 69. The client has recurrent asthma. That's good. This is some. Okay, so we got a math for nurses problem. The client has recurrent asthma attacks. The healthcare provider prescribes aminophenolin. Sometimes it's hard to say those, but this drug he prescribed 1,000 milligrams, and those milligrams, little tiny little sand particles, are going to be inside 250 mils of D5W, which is a liquid. Okay, it's an IV liquid, and he wants that liquid to be infused 30 milligrams an hour. Okay, so when we go to our medicine room, well, we have that medicine, but it's not this in the same dosage as the doctor is saying to give it. So we have to use the formula given to convert how much we're going to take from this vial. So how many mils of this drug should be administered? So if we have 10 mils, okay, it should be your first thing to do. It takes, inside that 10 mil is 2,000 milligrams, okay? So how many milligrams does the doctor say have? He said give 1,000, okay? So you need to have that 1,000 to where it's going to cross out each other on that 2,000 mark, so the milligrams cancel out. So it should be 10 on top with a 2,000 on bottom, then a multiplication symbol, another fraction line, and on top of that, where the 10 meet, should be your 1,000. Then you're going to do the math. 10 times 1,000, then what's left is 2,000. You divide the top into the bottom, and you should have 5. Because you're converting what you have on stock, the dosage that you have. You're converting that and turning and being able to use it to get these people their medicine. That's why you have to convert it. But I hope this helped.